We have seen colorful tapes wrapped around athletes' body in every game, thinking that they are cool and it might be something that will make them perform better. But what are these tapes and what are they exactly for? The tapes that we see in athletes when they play are called kinesiotape. Kinesiotaping is a rehabilitative method on which facilitates the natural healing process of the body by giving support and stability to muscles and joints without restricting the body's range of motion. It creates soft tissue manipulation that will help alleviate pain in every population, may it be pediatrics, geriatrics, or even athletes. However, studies haven't really confirmed it that much. To know if kinesiotaping method is effective, we are here to show 4 articles to know if taping really helps athletes to alleviate the pain they usually experience or if it improves their performance at any cost. PubMed Central, or PMC, and PubMed.gov were the electronic databases that were used for searching the articles. Here are the titles of the following articles. Temporal efficacy of kinesiology tape versus traditional stretching methods on hamstring extensibility. Immediate effects of kinesiotaping on quadriceps muscle strength, a single-blind, placebo-controlled crossover trial. The effect of kinesiotape on vertical jump and dynamic postural control. Kinesiology tape does not promote vertical jumping performance. A deceptive crossover trial. The first article, the study design that was used was controlled laboratory study. 30 male participants ages 18 to 22 years old who participate in recreational sport 4 times a week, asymptomatic from injury and with no history for previous hamstring injury, were randomly and evenly selected into 3 groups defining the nature of the intervention: static stretch, proprioceptive neuromuscular facilitation, and kinesiology tape. 3 experimental interventions of equal time duration were applied in randomized order: KT, SS, and PNF. Measures were taken at baseline, plus 1 minute, plus 10 minutes, and plus 30 minutes after each intervention. The temporal pattern of change in active knee extension was modeled as a range of regression polynomials for each intervention, quantified as the regression coefficient. ANOVA confirmed no significant differences in AKE between the 3 groups at baseline, with the baseline score for each subject is set to 100%. Repeated measures ANOVA revealed a significant interaction between time and intervention. Active knee extension scores at PNF plus 1, KT plus 10, and KT plus 30 minutes, which are shown here, were significantly higher than pre-intervention measures. Now on to the next article. A single-blind, placebo-controlled crossover trial was used as the study design. A convenient sample of 36 healthy volunteers ages 18 to 47 were recruited. 2 subjects did not complete the sessions and were excluded from the analysis. Subjects were tested across 3 different sessions, randomly receiving 2 experimental kinesiology tape conditions applied with the aim of enhancing and inhibiting muscle strength, and a sham KT application. Quadriceps muscle strength was measured by means of an isokinetic maximal test. 2 secondary outcome measures were performed. First, the single leg triple hop and the global rating of change scale. The minimum sample size required for 80% statistical power and 5% significance level was 31 subjects. Test-retest reliability for non-dominant side isokinetic peak torque test and single leg triple hop was calculated with a 3-layered approach. First, a repeated measured analysis of variance, ANOVA, was used to test whether the changes in IPTT between different sessions were statistically significant. A 2-way fixed model interclass correlation coefficient was then used to assess test-retest reliability. Interclass correlation coefficient values of greater 0.90 were considered indicative of high reliability. Third, the standard error of measurement was calculated to estimate the error associated with an individual patient's test score. A repeated measure ANOVA was then used to verify the stability of the subject's physical condition during the study period. Mean scores of IPTT and SLTH for the untaped dominant leg in 3 different sessions were compared, and the level of significance was set at p is less than 0.05. A paired sample t-test and the effect size were calculated to detect differences between the untaped and the taped dominant leg. So for the next article, a randomized controlled trial was used to determine whether the application of kinesiology tape had an effect on the vertical jump and dynamic postural control in healthy young individuals. 52 healthy subjects, free of ankle or lower extremity problems, were randomly assigned to either the experimental group or the control group. Each participant had their baseline vertical jump and star excursion balance test scores completed prior to tape application. Once their baseline measurements were taken, the participants were taped for either the real KT taping technique or the sham KT taping. Immediately after the tape application, outcome measurement was taken for vertical jump and SEBT scores. Participants were then instructed to wear the tape for the next 24 hours and return to the athletic training room for re-evaluation. At that time, the third measurement was taken for vertical jump and SEBT scores, and after the final outcome measurement was obtained, the participants were instructed to remove the tape. Group by time 3-way mixed model analysis of variance with time as a repeated factor was used to assess the effect of KT and vertical jump and dynamic postural control. Descriptive statistics were calculated for both groups at the 3-time intervals: baseline, immediately after taping, and 24 hours after taping. Main effect analysis was applied in the cases of significant difference among the 3 assessments. When appropriate, follow-up analyses were performed using lower-order ANOVAs and independent and dependent sample t-tests with Bonferroni collections. Now on to the last article. A deceptive, randomized, and crossover trial was used to investigate the true effects of kinesiology tape on functional performance in view of the weak relationship between functional performance and isokinetic muscle strength. 64 healthy volleyball players participated, and they are free from any cardiopulmonary conditions and any active joint pain or other related symptoms in the recent 12 months. They were ignorant about taping also. 20 participants screened out before the experiment and 6 dropped out due to scheduling conflicts. The test subjects performed vertical jumping tests under 3 taping conditions. First is a true facilitative kin tape, sham kin tape, and no kin tape. Under the pretense of applying adhesive muscle sensors, kin tape was applied to their quadriceps and gastrocnemius in the first 2 conditions. Mean maximum jump height and peak jump power were averaged from 3 attempts. Within subject comparisons were conducted by repeated measure ANOVA. Repeated measures ANOVA was used to test within subject effects of kin tape on the jumping performance. The global alpha level was set at 0.05. In order to avoid over-reliance on statistical tests, the effect size was calculated using established method. In brief, the effect size is a continuous measure ranged from 0 to 1, and it reflects the degree to which variability among observations are attributed to the intervention. Here is the overview of the results of all the articles. For the first article, with baseline scores not statistically different between groups and baseline active knee extension set at 100%, proprioceptive neuromuscular facilitation showed a significant improvement immediately post-intervention. Thereafter, only kinesiotape showed significant improvements in active knee extension. For the second article, compared with baseline, none of the 3 taping conditions showed a significant change in muscle strength and performance. For the third article, overall, there were no differences between groups in vertical jump maximum height, vertical jump average height, or the SEBT scores for the 3-time periods. Lastly, for the fourth article, out of 64 participants, 30 of them were successfully deceived and they were ignorant about kin tape. No significant differences were found in both maximum jump height and peak jump power between 3 taping conditions. For the conclusion for our research synthesis objective, the overall results of the 4 studies show that the use of kinesiology tape has little and no significant effects and has limited outcomes on promoting functional performance. The use of kinesiology tape in managing pain for sport-related injuries requires further research to know its effectiveness.